Hello, and welcome to the Medicine Matters Diabetes podcast. Earlier this year, the American Diabetes Association published their consensus report on nutrition therapy for adults with diabetes or prediabetes. We recently caught up with the first author on the publication, Alison Evert, who is a registered dietitian and certified diabetes educator at the University of Washington Neighborhood Clinics. I started by asking Alison about the composition of the document and the motivating factors behind its development as a consensus report rather than a position statement as in previous years.
Thank you for asking that question, because the process for position statements have changed with the American Diabetes Association. This process has been championed by the then Chief Scientific and Medical Officer, William Cephalou. He wanted the standards of medical care to be the go-to source of information for members and also other people in the diabetes community about how to practice evidence-based medicine around taking care of people with diabetes. When new scientific research is conducted and findings are published, as well as publications of consensus statements that are endorsed by the American Diabetes Association, these things will be incorporated into what is being called as living standards of care. So instead of being published just once a year, the standards of care are updated frequently. And since the current 2019 standards of care have been published, there's been 4 updates. And so recommendations that are new and reflect new changes in evidence-based practice in the topic of nutrition have now been incorporated into the standards of care. But this consensus group, the report, also then, because it was endorsed by the American Diabetes Association, was published in an issue of Diabetes Care. And how this is different too is that this time, instead of just a collection of people being gathered together to do this work, there was actually a national call for volunteers. And so people submitted applications to be part of this work. They submitted their CVs. And what they really wanted to do was to make sure that there was diverse representation of different types of nutrition professionals, as well as medical doctors and nutrition researchers on the committee. And they also wanted to make sure that people on the committee were representing different cultural and ethnic groups as well. And we had a patient advocate on our committee as well, somebody living with diabetes.
So it sounds like you had quite a multidisciplinary committee. How did you go about working together?
We chose 10 people, and what we did was we paired a dietitian in practice with either a physician, a MD, or a nutrition researcher or a nutrition epidemiologist, or we had a psychologist that does nutrition research. So we had this great kind of a team aspect of the research component versus comparing or combining that with the person that does the translation part. So it kind of made, we thought, kind of a unique team for our consensus group.
What influence, if any, did the ADA's last update on nutrition guidance serve in the creation of the 2019 consensus report?
We used the 2014 position statement as our starting point, and Will Yancey, who is an internal medicine doctor practicing and doing research on obesity, and a lot of his work is in people with diabetes as well. He's from Duke University. He was a co-chair of the committee with myself, and we met with the Chief Scientific Officer, Will Cephalou, and Sasha Ullman, who is the nutrition director, and we looked at the outline from the previous position statement. And then based on member questions and also evolving areas of research, we developed an outline of what we wanted to cover in this consensus report.
I wonder if you could give the listeners a little more insight into the role that published evidence played in the development of your consensus.
The ADA hired a research librarian to conduct a literature review of the inclusion-exclusion criteria that we had set for this evidence review. A really important point about this consensus paper is that though it was evidence-based, the recommendations presented in the report are an informed expert opinion of the authors after consensus was reached through our presentation of research on our conference calls and a discussion of the evidence.
So that being the case, what nutrition research would you like to see completed before the next consensus report is released?
So we need longer trials, we need more people in them. We also need research studies that are looking at ways that we might tailor medical nutrition therapy to different racial and ethnic groups, because we know that everybody doesn't eat the same way and everybody doesn't live in the same, in the same place. We also need to be looking at nutrition research in terms of different delivery methods. In technology now, how nutrition interventions use mobile technology, apps, and social media, and technology and internet-based interventions. We need more research on the cost effectiveness of nutrition therapy. And we need research on the different impacts of different eating patterns themselves, and then also compared to other ones. And then just also in research conducted in terms of different personal preferences, physiologic supports, co-occurring health conditions and such. So you can see we have quite a laundry list of things, and there's actually a section at the end of the paper where we ask each one of the members of the position statement to put in their wish list. So that's an important part that I might ask readers, to look at. And something that I forgot to mention about when we were asking about this consensus report and how it came about is the American Diabetes Association feels so strongly that this information should be shared with the diabetes community that they publish this, and it's online and it's available for free at their website, www.diabetes.org, and they have a professional section.
What sorts of issues does a lack of funding present to the advancement of nutrition research?
If you think about nutrition research, if you're studying oils or nuts or different eating patterns, thinking of a group that would fund that sort of research is really problematic. And if you think of a research trial that's lasting 3 months and you're providing every morsel of food and beverage to each participant, you can see how nutrition trials can, if they're really well conducted, are very expensive to put on, as opposed to giving a patient a drug or a placebo or the control drug.
What controversies do healthcare professionals need to navigate at the moment? And do you think any of the recommendations from the committee address them?
I think the biggest controversy is because of a majority of people that have diabetes are taken care of by their primary care provider, and a small percentage of people with diabetes are cared for by an endocrinologist. I think in that busy office appointment where you have 20 minutes or 30 minutes or 15 minutes with a patient, I think what people want is something that they could give people very quickly, like, this is the one thing that you need to do for taking care of your diabetes in relationship to how you eat. And unfortunately, even though I don't think of it as a controversy, I think that's one of the unanswered questions is, what can my patient eat? And previous position statements have reviewed the literature, and what we find is that there's a variety of eating patterns and different combinations of foods and beverages that can be used to help in the treatment or management of a person with diabetes. So even though it's not controversial, I think that it's not the answer that that a lot of busy healthcare providers want to have. They want to know what they can do. But I think one of the most controversial things that our group had to address was the real interest in macronutrients. And is there a specific macronutrient combination that works for a person with diabetes? And reviewing the evidence, we once again found supporting what previous position statements and what our consensus report said. There is no ideal macronutrient combination that's going to work. It's individualizing. It's sending that patient to work with a nutritionist, a registered dietitian, for an individualized eating pattern or an eating plan. But I think carbohydrate is a really important question that we get asked. And what we did find from our evidence review was that reducing the overall carbohydrate intake for people with diabetes demonstrated the most evidence in terms of improving glycemia. So that's saying that we should look at the carbohydrate component. We're not saying that it should not be interpreted as we're telling everybody to follow a low carbohydrate diet, but that by looking at that macronutrient in that individual's eating plan, that can really make a difference. And where I think about this or how I can describe is that when a person is diagnosed with diabetes, it's estimated that they've lost about 50% of their body's ability to make insulin. And so the biggest determinant of the postprandial glucose excursion is the carbohydrate component of the meal. So by reducing that carbohydrate component, that can definitely impact glycemia. And for example, as a registered dietitian, one of the things I say in terms of if I don't have much time as a healthcare professional working with a patient, the low-hanging fruit is what beverages our patients drink. I would have a hard time eating 4 or 5 pieces of fruit in one sitting, but if I put all that fruit into a blender and liquefy it, and it doesn't take much work or effort to consume that product, but introducing a liquid form of carbohydrate in a large volume like that can definitely have a significant impact on the glucose levels of a person with diabetes. So looking at the carbohydrate content, is definitely a controversial or a must often asked question. So one of the recommendations that the consensus group came up with, and we really carefully worded this as well, was that for select individuals with type 2 diabetes not meeting glycemic targets, or where reducing anti-glycemic medications is a priority, we do have the evidence based on our review to make the recommendation that reducing overall carbohydrate intake with a low or a very low carbohydrate eating plan is a viable approach for this group of people.
So that sounds positive. Anything else?
We did look at the evidence around using personalized nutrition approaches that examined genetic and also microbiome, your gut health. And based on our review, we can't say that there are specific recommendations that we can make around there. We just don't have the evidence yet around these personalized nutrition approaches for people with diabetes, as much as many people would like, to have a test that they can take. As one of the people that looked at the section said, not quite ready for prime time yet, but a very interesting and evolving area of research.
Since a lot of diabetes management occurs in primary care, what key takeaways did the committee have for this audience?
we know from time studies of primary care providers, and I work in the field of primary care. I manage nutrition and diabetes programs for 20 primary care clinics associated with an academic medical center. And I know my colleagues are really busy. And we know from time studies looking at how clinicians spend time that typically 1 minute of a 20-minute office appointment is devoted to lifestyle intervention behaviors. But I think it is really tough to give a person nutrition recommendations if you have approximately a minute or two. So if you don't have much time, encouraging them to choose an eating plan or a pattern, a Mediterranean, intermittent fasting, ketogenic, low fat, a plant-based eating plan, what a patient is willing to follow is what they will embrace, right? If I tell a patient I want you to follow a certain eating plan, that's likely not going to work if that's not something that resonates with them, correct? So if a clinician doesn't have much time, we actually put some areas of focus. And this is one of the consensus recommendations. And I'll just read it here. It says, until the evidence surrounding the comparative benefits of different types of eating patterns in specific individual strengths, healthcare professionals should focus on key factors that are common amongst all eating plans. And those would be that we should tell or encourage our patients to consume non-starchy vegetables, minimize added sugars and refined grains, and then choosing whole foods over highly processed foods to the extent possible. So these are some core strategies, regardless of the eating plan that patient chooses to follow. Eating more non-starchy vegetables, eating less sugar, less processed foods, and based on financial resources, because we know not everybody, based on socioeconomic factors, have perhaps a lot of money, that they can spend on their foods, but choosing whole foods over highly processed foods whenever possible.
So personalized meal planning sounds critical, but that sounds like a fairly time-consuming conversation to have.
The key takeaway is the meal plan needs to be individualized, and if the clinician doesn't have time to do it, hopefully if this is something that the patient really wants to work on, is refer that patient to somebody that has more time. So the macronutrient, that eating plan needs to be individualized. Another key takeaway recommendation is, and some of this is so common sense, but replacing sugar sweetened beverages with water. That's something that we should all be doing. Replacing saturated fats with unsaturated fats. Making sure that if a person does have complications from many years with diabetes, cardiovascular disease, chronic kidney disease, or gastroparesis, which is a really tough complication, to making sure that these patients have referrals as well to help them work on meal planning around these comorbidities. People with prediabetes should definitely be referred to a diabetes prevention program. We know that people with prediabetes, without changing their behaviors, are likely to develop diabetes in the next 5, 7, 10 years. So really encouraging clinicians to refer to diabetes prevention programs with a goal of incorporating 150 minutes or more of physical activity, improving eating habits, and working towards, if needed, for people needing to lose weight, a 7 to 10% weight loss. The consensus statement looked at the evidence around people with type 1 diabetes. And one of the take-home messages for clinicians that work with people with type 1 diabetes that hasn't been addressed before is the presence of obesity. And the panel determined that similar to type 2 diabetes, the presence of obesity and type 1 diabetes can worsen insulin resistance, glycemic variability, microvascular complications, and therefore weight management has been recommended as an essential component for individuals with type 1 diabetes as well. The position statement also recommended, because many people that have type 2 diabetes have also overweight and obesity, and people with type 1 diabetes with following, an eating plan for many, many years, we made the recommendation too that as a part of a regular assessment that people should be asked about disordered eating as well, because we're seeing rising rates of disordered eating in many populations with diabetes. I think finally, one of the consensus recommendations as a dietetic professional that I think I should be standing on a mountaintop and shouting would be that medical nutrition therapy based on randomized control trials, and granted ours are a little bit smaller in size than a lot of the pharmaceutical trials, but medical nutrition therapy can decrease A1C similar to many of the pharmaceutical agents that are out there. And I think often healthcare professionals that are busy write a prescription for a medication, maybe then working on eating behaviors that can have maybe a similar impact.
Thank you for speaking to us, Alison. You can find a link to the ADA's consensus report on nutrition therapy in this podcast's episode notes. You can listen to more podcasts by subscribing to Medicine Matters Diabetes with your preferred podcast provider or by visiting the website.